Nurses, and welcome to another video. In today's topic we will be discussing diabetes mellitus. This is intended to be a guide for nursing students on the subject. First, just a little bit of definition and a little bit of background about diabetes. So diabetes is a chronic disease in which the body either cannot produce the insulin or cannot use the insulin that is readily available. Every 3 minutes a Canadian is diagnosed with diabetes. 1 in 3 Canadians are living with diabetes or pre-diabetes, and diabetes can have a effect on the life expectancy on patients by up to 15 years, and all of this data has been taken from the Canadian Diabetes Association. So in this video we will be talking about two of the main hormones involved in diabetes, so insulin and glucagon. Insulin lowers the blood glucose levels in the blood. It is secreted by the beta cells in the pancreas, and its job has a crucial job in the body in metabolism, in the sense that it acts as a transporter of glucose, amino acids, and fatty acid across the cell membrane. So it allows glucose that is in the blood to be pushed inside the cell so that the cells can utilize it to function normally and be able to maintain normal metabolic functions. Glucagon, on the other hand, have opposing effects than insulin. It increases glucose levels in the blood. It is secreted by the alpha cells in the pancreas, and it works by stimulating the breakdown of glycogen stored in the liver to be converted into glucose so that the body can use it. If the blood sugar is high, then insulin will be stimulated so that the body can push this sugar inside the cells so that they can use it, and therefore glucagon will be suppressed. In the other hand, if blood sugar is low, then glucagon will be stimulated so that the body is able to increase the blood sugar levels, and insulin will be suppressed. Diabetes mellitus is the insulin problem, and there's usually 3 factors that affect this. Number 1 are the problems producing the insulin itself. Number 2, the body has problem with the sensitivity and how to use the insulin. And number 3 can be a combination of both. So what this leads to is it leads to a culmination into a metabolic disorder that results in hyperglycemia or high blood sugars. In this video we will be covering type 1 and type 2 diabetes mainly. So type 1 diabetes is an insulin deficiency. Beta cells that cannot produce the insulin that is needed by the body, and therefore exogenous insulin is required by the patient to be taken. Type 2 diabetics, insulin resistance or intolerance. That means that there is a certain amount of insulin in the body, or the body is producing insulin normally. However, the cells, they don't know how to uptake it. They don't know how to use it. So it's a problem with the cell's inability to utilize the insulin that's produced. And type 2 diabetes usually can be managed with diet, PO medications, or exogenous insulins. Some of the signs and symptoms of diabetes include polyuria, so patients will tend to urinate more. This is usually because the high amount of sugar inside the blood causes an increase in osmolality inside the capillaries. So what ends up happening is the body usually tends to reabsorb glucose by the kidneys, because glucose is a very important source of energy for the body. However, once it reaches a threshold, once it hits a limit, the body cannot reabsorb anymore. So all the excess sugar, the body needs to get rid of it, right? And the only way to get rid of sugar is to dilute it in water, because sugar sugar in itself, it cannot leave the body in a crystal form. We cannot urinate crystals out, right? So it needs to be diluted in water. Therefore, if you have too much sugar, the body needs to get rid of a lot of sugar, therefore needs to dilute it in a lot of water. So the water needs to come from somewhere. Therefore, you tend to pee a lot. The patients, when they have high blood sugar, they tend to urinate a lot. With the excessive urination, obviously the volume inside their vasculature is depleted, and they will feel that they're very thirsty, and they will constantly ask for some water to moisten their mouth because they do feel very thirsty. The lower amount of volume in the vasculature will lead to hypotension or low blood pressure, and tachycardia will result as a compensatory mechanism, right, to keep perfusion of the vital organs. Tachypnea usually happens when patients are acidotic, so patients will tend to breathe faster, hyperventilate in order to try to correct the imbalances in the metabolic acidosis. GI discomfort usually is caused by lactic acid buildup. They can present with decreased LOC. They feel generally unwell, weak, or they might complain of nausea and vomiting. So some of the clinical complications that we will be covering in this video will be hypoglycemia or low blood sugar, diabetic ketoacidosis or DKA, hyperosmolar hyperglycemic nonketotic syndrome or HHNS, and hypertension that is cause or a result of diabetes. So hypoglycemia is a very common presentation in the ER, patients who come in drowsy or decreased LOC, and we have to rule it out because it can mimic obviously alcohol intoxication, it can mimic behavioral changes due to head injuries, or it can mimic a stroke. So whenever a patient comes in decreased LOC, we have to rule out an episode of hypoglycemia. Some of the causes can be excessive stress, prolonged physical activity, malnutrition, fasting, or starvation. Insulin shock is a state where the body produces excessive amounts of insulin. So therefore, blood glucose levels are extremely low, almost like dangerously low. And alcohol consumption can also lead to hypoglycemia because alcohol prevents the body from breaking down sugar properly to use it. So some of the treatment for hypoglycemia is quite simple. So if the patient is conscious and able to swallow with no problems, then you can give them quick sugar such as OJ or apple juice or glucose tabs, and you have to follow that with a complex carbohydrates so that there isn't a spike in sugar and then they crash. So right, so it needs the complex carbohydrate performs a function that keeps the blood sugar a little more steady. We have to follow it up with some AccuChecks until the blood sugar is stable. In the other hand, if your patient's unconscious, and if they have an IV access, then D50W 1 amp can be given. If they do not have an IV access, then they can get glucagon 1 milligram IM. In some hospitals, they have medical directive that allow nurses to change the IV fluids to D5W at a certain rate, usually anywhere between 50 cc's an hour to 100 cc's an hour, and to notify the physician. And obviously, just we need to continue to check blood sugar levels until they stabilize more. So next, we're going to talk about diabetic ketoacidosis or DKA. Mostly happens in type 1 diabetics. So what happens is the pathophysiology of this is that due to the lack of insulin, the cells are unable to function properly because they cannot carry out their normal metabolic needs. So what ends up happening is the body tries to break down fats instead for an alternative source of energy. So the breakdown of fats, the end result will be production of energy. However, the byproduct of it are ketones. So ketones, they do produce acidosis when they accumulate in the blood. So also because the body is starving of energy, then what happens is the body will increase the hormones that antagonize insulin, right? The body doesn't know that it doesn't have insulin. All it sees is that it cannot utilize energy. So what it will do is it will try any means possible to be able to try to increase the energy available, right? Whether it's able to use it or not, then that's the other problem. And insulin is the key factor here that will allow the body to use the energy, or the energy in the form of glucose is just available, but the body is unable to use it. So hormones such as glucagon, growth hormones, cortisol, all these hormones antagonize insulin by increasing blood sugar levels. So because the body is being starved of energy due to the fact that it cannot push sugar inside the cells to use it properly, then it will have an increased requirement for insulin, because as the body goes on, there's more and more cells that become starved, and therefore you need more and more insulin in order to be able to maintain the function of more and more cells. Therefore, the insulin requirement of the body goes up, and it cannot be met by the body. It is worth mentioning that there is another condition called alcoholic ketoacidosis. This condition mimics DKA symptoms in the sense that, they will show up as metabolic acidosis. They will show signs and symptoms of DKA, the tachypnea, the generalized malaise, the change of mental status, and is usually caused by starvation with a combination of alcohol use. So what happens is, in a normal individual, the body is able to compensate for it to a certain point. However, it reaches a point where the body compensatory mechanisms cannot keep up anymore, and it goes into a state of shock almost, right? That the body will need to break down fat to provide the energy needed, and the ketones are produced, and the acidosis will follow up after that. So taking a good medical history, if the patient has a history of alcohol abuse, or if they have been drinking, or if they're eating and properly and stuff, would be good part of the assessment. So DKA, the impact of DKA, one is hyperosmolality due to the hyperglycemia, as we talked about earlier. Metabolic acidosis is due to the production and the accumulation of the ketone bodies as a byproduct of fat breakdown. And 3 is the volume depletion due to the osmotic diuresis. So when blood sugar exceeds the normal threshold that we said earlier, it will tend to excrete, will tend to at least want to excrete all the sugar, and it will need water to be able to do so. Some of the lab findings about diabetic ketoacidosis will include high blood sugar, high increase in serum ketones, metabolic acidosis in ABGs. So not everybody has a luxury of having an arterial line or having an RT available that can do ABG gases, but if so, it helps a lot. Increased serum osmolality, increased lactate or lactic acid, abnormal lab results in the sense of electrolytes will be in balance. So early stage of DKA, we will show decrease in electrolytes due to diuresis. The body is trying to compensate for it. So once we start treating the patient with fluids, like we say, to replenish the vasculature volume and stuff, then the electrolytes will show that it is the electrolytes will show that it's a little bit high because the patient is so dry that everything is hemoconcentrated. So that value for electrolytes is not accurate. Once we start to replenish the patient with fluids, electrolytes might come down a little more and more, even though we're replenishing those electrolytes like potassium, magnesium, phosphate, and calcium. Because as a patient starts to be rehydrated again, the vasculature volume starts to be replenished, and the amount of electrolytes inside proportional to the fluids becomes less. So therefore, it will show as a low electrolyte levels in your blood, right? And usually that happens, so that's how you know if the patient is being rehydrated or not. And obviously, continuously being able to replenish those electrolytes and monitoring are paramount in the progression of the patient treatment. Some of the treatment goals include improve the circulatory volume and tissue perfusion to maintain those vital organs with oxygen-rich blood, fluid resuscitation as needed, and we're gonna try to correct the electrolyte imbalances. A lot of hospitals, especially in the intensive care units, they have medical directives that allow nurses to replenish electrolytes, potassium, magnesium, phosphate, calcium, depending on the level, and you can give X amount, and that varies from hospital to hospital. The goal is also to decrease the serum glucose levels and also to correct the acidosis, and all of those things can be accomplished by insulin. So patients will usually be started on an insulin drip, and blood sugar will be tightly monitored to a desired level until patient's condition starts to get better. Next, we're going to talk about hyperosmolar hyperglycemic nonketotic syndrome, or HHNS. Usually affects elderly or the obese. It's characterized by very high blood glucose levels, has a very high mortality rate, and it usually has an underlying cause. So the pathophysiology of HHNS is that insulin is present but in inadequate amounts, so just enough to prevent the breakdown of fat. So the body starts to think that it's low on energy, because remember, the body the cells in the body can use sugar once there's insulin inside to be able to push it inside the cells, right? But because there's so little insulin available, even though there's a lot of sugar around, the body still thinks that there isn't enough energy available. So what it ends up doing is ends up breaking down more glycogen into glucose, starts to the process of glyconeogenesis in a attempt to try to increase the blood sugar available so that the body can use it. But it doesn't know that it doesn't have insulin, or at least that it doesn't have enough amounts of insulin. So this leads to a vicious cycle that the body keeps producing more sugar, producing more sugar, producing more sugar in this loop that leads to very, very high blood sugars, but is characterized by no ketones being produced. That is the difference between this and DKA. It causes severe dehydration with a very high serum osmolality because of the high amounts of sugars in the blood. The counter-regulatory hormones stimulate gluconeogenesis, like we say, and it usually takes a day or up to a week to develop. So some of the lab values include very high blood sugars, very high serum osmolality, and increased hematocrit because a patient is so dehydrated that they are hemoconcentrated, so it will show increase in hematocrit levels. And because a patient is trying to diurese, it will show decrease in potassium, phosphate, and other imbalances in electrolytes. So the management goals include the correction of volume depletion, control the hyperglycemia slowly. We have to check blood sugar frequently so that we know we're reaching our goal, and we have to identify and treat the cause. Next is the hypertension associated with diabetes. So hypertension is chronic and uncontrolled high blood pressure. And diabetes can be a cause of it. So diabetes, what it does, it causes an increased risk for endothelial damage. So the damage inside your arteries can be damaged. So once there's damage, the body will try to repair it, but then plaque can bind to that, right? And then once there's plaque, the arteries can become narrow, can become hardened, sclerotic. So what happens is when you have a narrow and hard artery, then you have a lot of vascular resistance. And therefore, the heart is going to work harder to be able to bypass that extra resistance in your blood pressure, in your artery, therefore leading to an elevated blood pressure in the patients. So chronic hypertension can damage very fragile organs, namely retina, so the eyes, the kidneys, and the microvasculature in the body. Some medications used in the treatment of diabetes, oral medications, they work in three ways, or there's at least three main mechanisms of actions, although there's many families of medications that, available for diabetes. So one of the type of families of medications, they work by trying to stimulate the production of insulin from the pancreas. For example, glyburide. Number two, another mechanism of action would be to increase the sensitivity of the cells to insulin, such as metformin. So metformin will try to help insulin bind to the cell membrane better, so that the sugar can be utilized properly by the body. Number three, medications such as acarbose, they work by decreasing the carbohydrate metabolism or breakdown and the absorption in the GI tract. So if your body absorbs less sugars from the GI tract, then you don't need to deal with higher sugar levels after it has been absorbed into the body, right? Insulins, they are the staple in diabetes treatment, especially in the hospitals. There's a rapid, the short-acting, intermediate, and long-acting. Remember, the long-acting insulin cannot be mixed with the other ones. The rapid and the intermediate, they can. In nursing school, you might have learned about the cloudy clear and clear cloudy. So cloudy clear, that means you inject air into the cloudy first and then to the clear. And then clear cloudy, that means you draw from the clear and then from the cloudy. Okay, so rapid insulin such as Humalog, they have a very quick onset and they last anywhere from 3 to 5 hours. Novolin R, they're shorter insulin. They take a little bit longer as an onset to kick in compared to the rapid insulin, and they last a little bit longer, anywhere from 5 to 8 hours. NPH, as an intermediate insulin, can last up to 18 to 24 hours, and it kicks in anywhere from 1 to 2 hours. And Lantus is, it doesn't spike, so there's no peak. And what it does, it keeps the blood sugar level in a nice steady rate or level, so that it's better control overnight or over long periods of time. So it's worth mentioning about gestational diabetes. It occurs in 3 to 20% of women during pregnancy. So the body cannot produce enough insulin to handle the effects of a growing baby. So women who have had gestational diabetes in the first pregnancy, they tend to have an increased chance for having gestational diabetes in subsequent pregnancies. And also they are an increased risk in the near future for developing a type 2. It is worth mentioning that a gestational diabetes goes away once the baby is born, and the baby is not born with diabetes. Diabetes mellitus, so just for the lifestyle changes, a lot of time the exact reason why diabetes develops in patients, it's unknown, but usually following healthy lifestyles can help reduce the risk of developing diabetes. Eating plenty of greens and a balanced diet, make sure we consume food from all our basic groups. We have to cut down on simple sugars so that our blood sugar levels don't spike up and they don't go up and down like roller coasters. We have to monitor our carbohydrate intakes. We have to engage in physical activities so that the sugar and the glucose that we consume is break down, and we keep the cycle going. And it's also useful to go on a yearly checkup. Make sure you go to your family doctor every year to make sure that everything is good, blood sugar levels are good, hemoglobin A1C, and your HDL and ADLs and all those things, make sure we keep them in check. And that's it for this video, guys. Again, this was intended to be a video for nursing students in the topic of diabetes, a very quick guide. If you like this video, give it a like and subscribe, and I'll see you on the next video. Thank you very much.